Hello. Just
Hello.
just recognized that I had a waiting room set up, so I apologize having to get you guys all admitted. Typically, we won't have you don't have to wait. You'll be able to just join without me admitting you to the class. And sorry, I'm running just a little bit late. I have a 4 p.m. class right before y'all, from 4 to 5, and then from 5 to 6 to y'all, and then I have a 6 to 7 class, and so I'll do absolutely everything I can to make sure and respect all of our time and to try to stay on time. If y'all could just give me a window of plus or minus 5 minutes. Hey, Bubba, that's my son. They'll see him. You come say hello. You want to come wave at him? What are you doing, man? Chasing the dogs? Don't let you. Yeah. You want to come say hello real quick? Okay. Hurry.
Oh, so sweet.
This is Logan. He is my little man, and he lost a tooth. First tooth. Show him. Yeah, show him. Oh yeah.
I can't see it.
Yeah, you can. Yeah. Yeah. All right,
Uh-oh,
buddy.
sounds like the tooth fairy's coming.
Yeah. Love you, Bubba. I'll see you in a little bit. All right. Peace out, homie. All right.
Don't do like I do and forget about the whole tooth fairy thing and all I had was like a $5 bill. And it was like I had already missed the first night and made an
Like
excuse.
I owe
So
you. Yeah.
we had to do the whole like, okay, we're just gonna have to do $5. Like,
What does it do? Like
Jesus.
charging interest. Yeah, we've given the same silver dollar back and forth like probably like 7 times with my daughter, and now he got it, and they have yet to recognize it's the same one. Yeah. So thankfully we're hanging in there. But yeah, it costs a lot now for losing. I mean, like I got like 10 cents when I was a kid. Like one time I think I got like uh just a roll of pennies, like literally like a roll of pennies. Yeah. Man, inflation, folks, inflation's happening even with the tooth fairy. Um so yeah, I will typically get us started um about 5 after, just to give everybody time to get here. And so, feel free to, to join as soon as you can, but know that if you have to join later, or if it's like, even 30 minutes later, that's completely okay too. Okay. All of these are optional. All of these meetings will be optional. I record each one and we'll be posting the videos on Monday, the following day. Um, with uh, with this class and my next class, which is the child and adolescent class, we cover a lot of the same topics simultaneously, except that we're going to cover it from different perspectives, obviously. And there's some resources that we talked through more so with the child and adolescent side versus the adult side. But if you can follow along in your syllabus, the diagnostic sections per each week, that's what you should read in the DSM. In other words, so like the textbook for the course, the DSM-5 TR, the text revision, the green one, not the purple one. You'll find that if you read beforehand each week, or approximately read beforehand each week, those diagnoses, that Sunday following that week is when we will cover those topics. So in other words, if next Sunday, we will talk through neurodevelopmental disorders. Okay. All right. So this class is pretty straightforward tonight because we're not going to jump into a whole lot of actual content just yet. as much as I want to talk through expectations and what to, how to be successful in this class, I'm going to pull up your syllabi real quick, your syllabus, and talk a little bit about the grades and all that stuff so that you can feel hopefully less anxious about the class. Yeah. Let's see. There we go. All right, everybody see that syllabus okay? Perfect. And I realize that many of you have had me before, and for those who haven't, just a quick introduction. So I am Dr. Armstrong. I'm a clinical and forensic lifespan neuropsychologist, which means that I am a doctoral level licensed psychologist here in Texas, but who has an additional training, additional residency in all things on the biological side with the brain and central nervous system, in addition to understanding things about like the medications and how different physical injuries to the brain result in either personality change or cognitive decline, emotional functioning, differences, personality stuff. Yeah. I've been in practice for about 10 years, and will have been teaching at Amberton full-time as a full-time professor 10 years in September. So this September will be my 10th year here at Amberton, and which also means that my student loans get forgiven. So we've got that going. And when I say student loans, I mean $500,000 is getting forgiven. $500,000. Yeah. It should not have cost me that much to have earned the degrees that I've earned. What happened was, that's kind of a joke to say it like that, but the truth is, I was diagnosed with ADHD in grad school. And prior to that diagnosis and being treated for it, it took me about 6.5 years to get through undergrad. I transferred 4 times in undergrad, and I ended up taking, I think it was like, 200 something total hours for undergrad hours, but only needed 120 to graduate. Because every time I transferred, I'd lose all the hours and all that stuff and just kind of start over. And then once my ADHD was diagnosed and treated, it took me 3.5 years to take, I think it was 120 course credits, which also included a dissertation that was defended, 2 additional research publications, a total of 3,000 hours for practicum, and 2,000 hour pre-doctoral internship. Passed the licensure exam, all in 3.5 years. Once my ADHD was treated, so I had a master's and a doctorate and all that stuff completed. I'm telling you that because, and we'll talk about in this class too, but I'm very passionate about neurodevelopmental disorders, particularly ADHD across the lifespan, because it can be a very devastating thing. And for me personally, I wouldn't trade the experience or learning what I've learned as a result of the process, but I also wouldn't wish that on anybody. With all that being said, I do have ADHD. I am very good. Some of my strengths as a professor include being able to hyper-focus, and I will share with you guys detail on some of this stuff that is, front of the line research that you can feel confident that you know more about some of these topics than anybody else out there. the downside to being a professor with ADHD is, and especially the fact that I teach the biggest classes here at Amerton, is I've got about 120 students, and I do the best I can to respond to everybody as quickly as I can. But there are times that I might miss your email or message, and the best way to truly, to be honest with you, the best way to get in touch with me is messaging me through Moodle. I used to say through Gmail, but don't do that anymore. Gmail is that the Amerton account at larmstrong@amerton.edu. I get so many emails through there. It's very easy to miss a student's email. So if you can message me through Moodle, I've got it set up now to where it'll notify me and will hopefully start reminding me whenever I haven't had a chance to reply yet. If for some reason you've messaged me and you can't get in touch with me and it's been like a day or so, or give me like a day and a half, about 24 hours, feel free to remind me. And please know that it's not anything personal, and it's completely okay to say, hey, just checking in on this message, just seeing if you had a chance to look at it. A lot of times I remember you messaging me. I'm in the process of doing like 400 other things at the same time. And then when you send me a reminder, it reminds me and pushes it back to the front of the line so I can get it done. And that's completely, I wish I didn't have to ask you to do that, but, and I used to not have to ask you to do that, but since I do teach about 120 students every semester. And so it's kind of had to turn into that over time. Because I used to only teach like 60. By the way, 60 is the full-time load for teaching. Yeah. Which makes me happy though, because that means I get to see all of y'all, I get to know all of you guys. And I also am excited about you all getting licensed someday, because I'll know and feel confident about what you know. And as soon as you get licensed, I wish you would please reach out and tell me that you're licensed, because either one, I'll offer you a job at my own practice because we've got so many incoming referrals that we can't keep up. Or two, I will gladly put you on my referral list, because there are so many referrals that we are getting that I can't find any counselors right now that are accepting new patients. Yeah. Last week, through just Psychology Today plus our phone number at the practice, we had about 23, I think it was 23 new counseling referrals for kids and adults. 23 referrals in 1 week. That prior to the pandemic, it averaged about 3. Yeah. And we've had that many new referrals every week for the past 3 years now. And every counselor I know is completely full, has a wait list. Yeah. So you're going into the right profession. And yeah, like I said, once you get finished with all this someday, please let me know so I can send you some clients. All right. So we talked about the best way to get in contact with me. Please don't, you can call the number right there, the phone number, extension 149, but I'll be honest with you, I've checked that voicemail literally one time in 10 years. And I get an email like every year. It's like, Dr. Armstrong, you should learn how to do this by now. And I just shamefully avoid it because it's just a very complicated system and it's hard to reply. So just dodge all that. Send me a message in Moodle, and that's probably the fastest way. If there's any event of an emergency, if there's just something you absolutely have to get in touch with me about, I'm giving you, this is my cell phone number. You're welcome to call or text. Please use that, as last case scenario or worst case scenario. Also, that's only for non-clinical purposes. So if you had somebody that you wanted to refer to my practice or for testing or whatever, I appreciate that. But rather than email or text me or call me or give that number to any kind of prospective patient, just go through my practice contact information if you don't mind. That just helps me separate my cell phone from the practice side of stuff. Okay. Otherwise, if if it's a year from now and you've got questions about practicum or something, feel free to give me a call, leave me a message, and if I can help you, I would absolutely love to help. Okay. All right. With this class, you will need the DSM-5, and it's the green book. We already talked about that. I don't care if it's digital, virtual, spiritual. I'm just kidding. I don't care what format it is, but I would highly, highly recommend that you buy it. Even if you're a school counselor, even if you don't think you'll ever need to actually diagnose, you need a copy of the DSM-5, and it's going to be a book that you will reference frequently enough that it's worth buying it. As much as I don't want to, tell you how to buy a super expensive book, it's one of the books that you will absolutely need. Essentially, almost all of my quiz questions and test questions come from the DSM-5 TR. Almost all of them. The rest of the ones that don't come from that book usually can either be found in my PowerPoint slides, and then if not there, or if there's confusion there, your next step is to use our friend Google, and maybe perhaps Google Scholar would be a better one, to do your own outside research. And I'm going to say that again just to make sure we're clear. There will be questions in your quizzes and your exams that will ask things that are outside of what we've talked about in class. Questions about medications at times, things like that. Please know that I won't teach you everything like directly that will be on your exam or quiz questions. Some of it will require you to go outside of that, as it is expected in grad school to do your own research and to come up with the right answer. Now, here's the cool part about that. If you do your own research and decide that none of my answers are right, or it tells you that you got it wrong, and you feel that the research you did suggests the one you chose was right, all you got to do is email me, show me the work that you did, show me where you found the information you did, and I will give you your points. Even if I don't agree, even if the question says you got it wrong, we can agree to disagree, because now that you're at the master's level, you are an expert. And as long as you can show me like, hey, I'm not just disagreeing with you because I think it's a terrible question. I'm actually disagreeing with you because I found this in the research literature, and I think you're wrong. That's wrong. I love that. That's worth points. I would rather you do that than just regurgitate what you memorized to be the right answer. Does that make sense? Cool. So if you run into something on one of the exams or quizzes where one of the questions seems incorrect, you're welcome to let me know, and I will absolutely, and I always do, go back and double check all of that at the end of the semester. Especially if like 70% of the class misses one, I always end up usually getting credit to people. But this is your time to figure out what you think the right answer is. And sometimes you're going to disagree with the official test answers. I don't do that because I like to be a mean professor. I do that because you need to get more comfortable with feeling confident and knowing what you know, rather than what your grade reflects or suggests that you know. In other words, I made 3 C's in grad school, and I can tell you in those 3 classes, I learned more in those classes than I did my other classes where I made like 100 soon. Okay. It's not that your grades don't matter. What matters is you learning. That's really where everything like points to. And ultimately, the quicker you can switch to caring about what you're learning versus what your grades are, the more confident and competent you're going to be as a counselor. Okay. We're going to take just a real quick break. I need to use the restroom real quick, and I need to grab some water, but give me like 2 minutes and 2 or 3 minutes. I'll be right back. You're welcome to just kind of talk amongst yourselves while you're doing that, but we'll do that real quick and then we'll keep going. Okay. All right. Thank you for that break there. Get some water. My allergies have been acting up a lot past couple of days with all the weather changes and everything. And I took an allergy medication that's making my mouth dry. That, and I also talk a lot as a professor, so that kind of that happens as well. All right. So just to kind of outline some of the general things that we're going to cover in this course. Except for your week one quiz, which is due this upcoming Wednesday, the rest of the quizzes won't be due until the end of the semester. So every semester I get like 2 or 3 students that will give me a bad rating. And they always say, basically they give me a bad rating because they wish that I would make the due date for each week rather than giving you the whole semester to get stuff done. That's completely fine, but I'm probably never going to change that because ultimately y'all are adults. Life happens. It's okay for you to sometimes get behind, and it's going to happen. You're going to get behind because quite frankly, there's too much information to try to cover in grad school in 10 weeks, and especially if you're taking more than one class at a time. And so the best I can do to be flexible on my side, because I recognize that, is to give you the entire semester. Okay. I think I give you 2 attempts per quiz, and I think 3 attempts on the exams, and each attempt is untimed. Okay. So if you fall behind, do the best you can to catch back up, but please know that you've got the whole semester here to get stuff done. Each quiz is worth 5 points each. There are 8 quizzes. You won't have a quiz on week 5 or 10 because that's when we have our midterm and our final exam. The quiz questions tend to be a little bit harder, in my opinion or experience, than the actual exam questions. And I do believe that your exams are already open. So like those are open to take as soon as you're ready. And both of those are also due at the end of the semester. Okay. They are all multiple choice questions. And if you come across an error, like if there's just no right answer and you're like certain like this is an error, please let me know, because I don't put it past myself to have made a mistake. I've tried to iron all those out over the past 2 or 3 semesters here, but if you run into something, please let me know, because I'm always wanting to make it better. And also know that I'm going to be fair with the grades. I care about your learning more so than I do about arguing whether or not you should get 1 or 2 more points. And ultimately, I'm going to look and see how much did you actually engage with the course content that I've posted, because it'll tell me if you ever clicked on or downloaded like a PDF that I shared, or did you ever download the PowerPoint slides or watch any of the videos or so forth. I can look at those kinds of details when it comes to making decisions between whether or not you get a B or an A in a class. Okay. I do always go back and look at the exams and quiz questions to make sure that those are fair. And if they're not, then I will be fair to the class and give you credit for things that that otherwise weren't taught to you, or that for bad questions, things like that. Okay. So for this class, we focus primarily on the adult side of psychopathology, and in the child and adolescent side of this class, we spend most of that time talking through the neurodevelopmental disorders, where for this class, we talk about those disorders, but only briefly, because we quickly go and move into bipolar and schizophrenia and depression much quicker than we would otherwise in the child and adolescent class. I do the best I can for this class to stay on schedule. And so you'll find that we don't cover every single diagnosis that you come across in the DSM-5. And it's not because you shouldn't know about it. It's literally, I've tried to pick out all the disorders and diagnoses that you're most likely to come across in practice. Okay. With that being said, too, you're also welcome to ask me questions outside of those diagnoses. If there's something that you want me to talk about or to share my thoughts on, I'm always more than happy to do that. Another subspecialty of mine, and I promise I don't specialize in everything, but what makes me a little bit unique as a psychologist is that I have an additional postdoctoral master's in clinical psychopharmacology. And so in some states, that additional education and training experience allows me to prescribe medication. And Texas is not one of those. And so I don't prescribe medication, but I do a lot of consulting with prescribers on medication, and I testify in court on these. And so I'll share a lot of information that I have about the medications of all these disorders, or for all these diagnoses. But that information will be covered in multiple classes, not just this one. And so we don't always go into the deep dive of it all as much as I wish we could. But you will learn a lot about the medications. The other thing about this class is to remember that many of you, this might be like your first or second class, or even like, pretty early on in your education here. And it's going to feel like initially that you've gotten in over your head, because we're going to use all kinds of words that you've never even heard about before, all kinds of like neuroscience terms and psychopathology and all that kind of stuff. Like, don't be discouraged. Don't drop the course. It's completely normal to feel overwhelmed by the amount of information and just the new language of it all, especially in the first few weeks. This class, is one of the first classes I took in grad school. And I remember sitting down with the DSM, like in the class, I'm like, this is gonna be a cool class. And I get there and they're talking about all kinds of diagnostics and, even statistical kind of stuff. And I just remember my eyes just being wide and being like, what did I sign myself up for? It's okay to feel like that. You're not going to fail the class. You're not going to learn everything there is to learn in this class. That's also okay. Even if you memorized everything that we taught in this course, you would still not know enough to be competent as it relates to diagnostic or even from a counseling standpoint, using it effectively. The competency comes from experience in application and just time. Because you're going to learn this stuff over and over and over and over and over and over again. You're going to graduate, get your license, and guess what? You still have continuing education that you have to do every year. You're going to keep learning this stuff from here on out, and your expertise is going to build. It's not something that is going to be built. Okay? So give yourself some grace. Let yourself loosen up at least enough to have fun with it and just to absorb as much as you can, knowing that you're not going to absorb everything that would be helpful for you to know. And existentially, there's nothing you can do about it. Okay? But I promise you, I teach from a perspective that I want this to be practical and usable. And I don't expect you to memorize the DSM, nor do I have it memorized. Okay. When I go testify in court, I always bring a little desk reference. Because I'm telling you, I'll have an attorney, they'll say, well, so Dr. Arpo, no, tell me, was that their first currently in an acute episode, or, how do you determine that? Well, I have no idea if they're even telling the truth if I had it just memorized, because I don't have it memorized, which is why I have the book. If I can get you to a place by the end of the semester to where if you thought somebody had anxiety or generalized anxiety disorder, you could pretty quickly, within 10 seconds, find the right section in the DSM to read about. That means that you know it well enough to use it clinically. Does that make sense? So if we can get familiar with this diagnostic manual enough to where we know what we don't know and can go find it, that's the goal of this class. Okay. All right. Let's go back to our class. And all right. So, what questions do y'all have for me so far about any of that stuff? Questions about the exams or quizzes or anything?
Nope.
Okay. All right. Well, let's spend just a few minutes jumping into some of the week 1 PowerPoint slides. We're not going to cover all of it, and we probably won't get too far before I have to switch us over to my next class. But if you want to open up the first week 1 PowerPoint slide, you can follow along that way, or you can just follow along on your screen there. Real quick, just to kind of do some discussion, we won't spend a ton of time, but let's talk about some of the questions related to making a diagnosis, okay? Because as counselors, there's a lot of debate out there on whether or not, people should diagnose or when they should diagnose and how to make diagnoses and so forth. And I'm just curious to hear some of y'all's thoughts on um, why is it that making a diagnosis, a psychiatric diagnosis, psychological diagnosis using the DSM-5, why is that included in your scope of practice as a counselor? Why?
Well, I would think that once we get an idea, at least a general idea on what the diagnosis may be, then we can have a better understanding of which tools may be more effective to help the client.
Absolutely. Because in other words, I would say that implies that you wouldn't know what tools would be effective unless you kind of know what the problem is. Is that right? Yeah. Yeah.
Yeah.
Any other thoughts?
Dr. Armstrong, hi. I am a school counselor. I have been a school
Uh-huh.
counselor for 15 years now, and I'm just coming back from my LPC track. So,
You guys,
lot,
we get you back to the dark side.
I know, right?
Yep.
But a lot of times we have to collaborate on a multidisciplinary team. We have kids that go to treatment, outpatient or inpatient treatment, and speaking with LPC, psychologists, psychiatrists, social workers, clinical social workers, everything. We're constantly, trying to make sure that we have a treatment plan in school, outside of school. And so knowing the terminology and being able to diagnose, sometimes we can implement 504 plans for our students, or a special ed referral if we need to. So it's definitely, you need that medical diagnosis in order
Yeah.
to go forth with that. So
Absolutely. And just so you know, for the school counseling folks that are out there, so I spend probably about 40% of my practice is pediatric, and I'm at the state level on CEA's list of independent evaluators. So like when the school does testing and the parents don't agree with it, they're legally obligated to pay for an outside person to do an evaluation. And that's where I don't do the full FIE, but I do all the psychological side of it. And then serve frequently kind of as a middleman between parents and the school, working with advocates and even attorneys a lot of times, just to help everybody get on the same page. And yeah, just I love it. I love being in that position because I'm not on the school side, I'm not on the parent side, I'm just on the kid side, and I don't have to worry about politics, whether or not I'm going to keep my job, if anybody's upset with me. um it's pretty straightforward. But you mentioned that, and I bring that up because even if you're in the school side of stuff, even though you won't make that, even though school counselors don't make diagnoses in that setting, in my opinion, you still need to know how to make a diagnosis, because otherwise you won't recognize, you don't know what you don't know. And somebody like myself can come in there and just pretend like they know what they're talking about. And if you don't know what they're talking about, you're not going to be able to help as much as you could. My other passion there is that a lot of school counselors will say, well, why do we have to learn all this stuff? Because we don't ever diagnose yet. That's my response. And I know it's always kind of been talked about, but the truth is, at some point, Texas is going to recognize that the liability of mental health or students' mental health they could save a lot of money in insurance. In other words, if they switched liability to a licensed mental health clinician in the school, i.e. the school counselor, by allowing them to actually practice counseling and then separating themselves from that liability in the event that something bad happens. And so, in other words, I think eventually they're going to have school counselors actually independently licensed to practice, and then so that they can separate schools from the liability of the practice of mental health and counseling. But that's not, I mean, it's not just my opinion. That's other people's, like, we all kind of think that's the direction it's going. And so it's very possible that within the next decade that school counselors will be making diagnoses. All right. So just to speed us up just a bit, there is a lot of pushback. So let's talk about some of the cons. What are some of the downsides to diagnosing? What would y'all say?
Fear of coming up with the wrong diagnosis.
Yeah, like being wrong, right? And potentially doing harm. Yeah. Yeah. Sorry. I'm trying to, somebody had some background stuff going on there, but I accidentally clicked on the wrong person. So being wrong could potentially harm client. How would that harm them? Everybody's like, this is our first day of class, Dr. Armstrong. That's why we're here. We don't know the answers yet. What do y'all think? So tell me.
I would
tell me
just
some of
take a wild guess with
Yeah.
the misdiagnosis. The treatment plan could be wrong and it won't be beneficial to the individual that you're seeing, and it can make them possibly worse because you can be doing damage.
Yeah,
with their healing
absolutely.
process.
Yeah. So, to give you an example, somebody with major depressive disorder with psychotic features versus schizophrenia, and you diagnose them with schizophrenia, and rather than major depressive disorder with psychotic features, and then you tell them essentially they go look it up online, schizophrenia and not major depressive disorder with psychotic features, and realize this is a lifelong thing. My whole world is over. They subsequently become hopeless and commit suicide. There are patients, not my patients, thankfully yet, that specifically has happened to. I know people who have worked with patients where that has happened to some of their patients. I'm not saying I've never made a wrong diagnosis. I have, and will, as much as I don't want to do that, I probably will again. But there is a gravity or a power behind making diagnoses that if we get it wrong, there is potential that this could hurt clients. Yeah. What other concerns about making diagnoses? Like just general concerns.
I would think like after you diagnose, understanding like what would be the treatment plan from there or how to guide that client from there.
Sure. How to translate that into something clinically like relevant, right?
Right.
And that's a really good point. And this is one of the things I talk about to my patients. In fact, what I say is that, we've got this diagnostic manual with a bunch of different discrete diagnostics or so-called discrete diagnostics that ultimately, if these labels can't tell us what to do next or how to make life better because of that knowledge through treatment, then they're worthless. They're just made up labels. Because if that label, you can have a label or meet the diagnostic criteria for a label, but if that doesn't tell us what to do about it, if that doesn't give us or shed some light on like, okay, well now, because we've got depression, that means we've got to do this, this, and this, and that in order to not have depression anymore. If it can't do those things, we might as well just get rid of the label, because what's the point of the label, right? it has no value outside of what it can shed light on as far as it relates to treatment. There's a little bit, you're gonna be like, whoa, this is kind of out there, Dr. Armstrong. I don't know if I believe that yet or not, but I want to tell you the DSM-5, your professor who loves diagnostics. When I was in grad school, I signed the petition, like the national petition against using the DSM-5 diagnostically. I remember like the passion, like the DSM-5 is just terrible. You know, we shouldn't have any diagnoses. We're pathologizing the normal human experience and, you know, all my existential stuff. And I am still very much an existential humanistic psychotherapist. And so I can relate even back to my past self. And what I tell my patients is that, and this is the truth, everything in our diagnostic manual that you come across, like, for example, for, gosh, what is it? For a lot of these disorders, you've got to have symptoms for like, you know, 6 out of, or I'm sorry, at least like 5 months out of 6 or something like that, or something ridiculous. It's like, you know, you got to have it for 6 out of 10 of these symptoms for 6 months in order to officially have a diagnosis. But if you only have 5 of those symptoms, then you don't have it. And that makes no sense, right? It'd be like getting an x-ray on a broken bone and then saying, well, the crack isn't long enough, so it's not broken, right? It's still a broken bone. It might not be like, of, you know, much as typical, but like it's either broken or it's not broken. Psychiatric diagnoses try to make that same assumption by having on-off switches of it, like you either have it or you don't. None of that makes any sense, because what it hinges on, all of our diagnostics hinge on the fact, how does this affect this person functionally? So if I have ADHD, right? Neurologically, I have an ADHD brain. It doesn't matter where I am, who I am, like, you know, what's happening. It's still an ADHD brain neurologically. But I won't have a diagnosis of ADHD. If I were a billionaire on an island and I just had my only responsibility was waking up and rolling over into my beach bed and just watching the waves come in every day, guess what? I would not have ADHD on that island. Same brain, everything else the same, but I wouldn't have ADHD there because it's not affecting me functionally. But because in real life, I'm not a billionaire on an island. I have a job, have kids, right? It affects me functionally, which is why I'm diagnosed with ADHD. It's the same thing with depression, schizophrenia. All the diagnoses in here hinge on how does that affect the person functionally. And if it doesn't, there's no diagnosis. Does that make sense? It's just harder because we know, like, person with schizophrenia would still have the neurology of schizophrenia and the pathophysiology going on in the brain, even if they were a billionaire on the island. But if it's not affecting them functionally, they wouldn't have schizophrenia from a diagnostic standpoint. This thing was written, by the way, this was written for the court of law. It wasn't written really to be much help clinically. It's written for the court of law because this book is what's used in court as it relates to disability determinations. It's used in schools to, you know, in some ways to figure out like accommodations. It's used on death row, whether or not somebody gets a life sentence versus like executed. So you're not going to read about treatment in this book. And you're going to read about it as if it seems like they're real confident, like that we can separate bipolar from depression, from ADHD, from OCD, from autism, from Tourette's and tics. But the brain doesn't care about all those labels. Most of this stuff shares overlap in the underlying parts of the brain that contribute to the symptoms. For example, ADHD and autism are probably the same disorder. It's just that autism is a subtype that predominantly affects social skill like development and the ability for aspects of judgment in a way that it doesn't seem to affect the same capacities as much for people who have ADHD. Although it's pretty true and well accepted that if you have autism, you probably qualify also for ADHD. If you have ADHD, you probably have a lot more autism trait than the vast majority of people out there who don't have ADHD. You know what I'm saying? There's overlap between all this stuff. So I'll end up teaching you a lot about that overlap so that when you hear a client say that they have OCD, you will always know, hey, I should probably rule out bipolar. I should probably rule out, I say rule out, I should probably also in the back of my mind, remember that there's going to be some mood instability there. There's going to be some generalized anxiety there. There's going to be probably a risk for ADHD, if not autism as well. And you're going to know why all that relates to one another as a result of this class. Okay. All right, I'm going to wrap this up there because I got to move on to my next class. But before I do, any questions, concerns, anything like that?
Dr. Armstrong, is your book a little smaller?
It's way smaller. This is
Okay.
this is the desk reference.
Okay.
Yeah.
I'm like,
You're like, man, mine was a lot bigger than that.
yeah.
You like the one at my office is like that big. It's like the standard version. This is just my like travel version that I leave at home whenever I need it.
Okay.
I have one even smaller than that. It's like a tiny little book like that one. Yeah, but you probably bought the big one, and that's the one that you need for the course. It's got all the stuff that you need in it.
Okay.
Yeah. Any other questions?
No, I have you again next class. So.
Oh, awesome. Well, we wish y'all could just stay online here, but you'll, I guess, have to switch to the next invite there. But well, feel free to reach out to me, folks, if you do have questions or concerns. Keep an eye out for emails this week. I usually try to email at least once a week, just kind of touch base with everybody. And then if there's anything I can do to help, please let me know. We'll plan on next Sunday. All right.
Yep.
You'll have a great rest of your evening.
Thank you, sir.
You too.
Take care.
Mhm.